All right, so I think the one thing I want to make clear up front is that we're going to be doing ever more amounts of lower extremity revascularization. Why? This paper just came out, or is about to come out, and it's going to show us that over time, patients who are revascularized with intermittent claudication a little, but more with critical limb ischemia, actually save their legs. This is a cohort of 104,000 patients in England, and just to make this clear, this is intermittent claudication, and these are different levels of critical limb ischemia, ranging from rest pain all the way to Rutherford 6. Okay, and what you can see is the sicker the patient, the more likely they are to get benefit, and that doesn't matter if it's endovascular or surgical. We're going to be doing lots of revascularization. I hate quoting a paper from someone who's on the stage, but I have a few slides now in a row from Phil's group because it just makes the point so nicely from VQI. If you take a look, this is 2,300 patients who underwent lower extremity bypass in between 2003 and 2011. And the first thing I want to show you is that over time, the number of procedures performed as secondary procedures increases. So it doesn't matter if you're starting with patients who have claudication in the light gray or critical limb ischemia in the dark gray. We are going to be doing ever more repeated procedures, and the earlier you pick up the need, the better things will be. Again, from the same paper, you can take a look here whether it's vascular intervention or bypass, whether it's claudication or it's critical limb ischemia. The first thing I want to say is that we used to think, or I think some of us still think, that you are way more likely to need a second procedure if you start off with an endovascular approach rather than a surgical approach. Now, accounting for the smarts of the physicians who made the decision as to which one to offer, you can see here that by 2011, the rates of requiring a secondary revascularization range from 22% to 19%. This is not a really big difference. This just suggests that both kinds of techniques really need to be followed up because they're going to require secondary interventions. And of course, we like to do everything perfect the first time, but people who need a secondary intervention, just as an aside, end up doing worse. This is their revascularization and amputation-free survival. And whether we're talking about, this is the first, people with the first revasc and people with the second one, and the secondary ones always do worse, whether we look at RAO or male-free. All right. I think there's some good evidence, although this is one of several that I picked. This is one of the earlier ones, demonstrating that surveillance reduces the rate of total failure and adverse outcomes. And in the study of nearly 300 patients, what you can see here is that the patients who got, the greater the screening, the less likely they were to have amputation later on. Now, I think the real reason I was asked to give this talk can be seen from this slide. This is the best critical limb ischemia study, which obviously is what we all think of as the premier study in critical limb ischemia, and this is the schedule of measurements, when they're making measurements. And so just take a look at arterial duplex on the bottom, and you can make measurements at 1 month, 3 months, 6 months, 12 months, 18 months, 24 months, 36 months, and 48 months. And this is basically saying, do whatever you do at your own institution. This was not a mandate to do it at this time point. This was offering the ability to do it whenever people said they routinely get measurements. And so I actually don't think that there's any standard, or there wasn't any standard at the time that this was created. So I want to make one definition. What does screening mean? Screening can mean clinical examination. The foot may be a different color. The pulse may be worse than it was before. An ankle brachial index is a good way to do a screening as well. Has the ABI changed? And obviously duplex ultrasound is something that would be at the highest level or order. So I am happy to say that a group of people got together, and Gene Zierler led this committee, and they created a nice guideline that came out of the Society for Vascular Surgery. And because I actually do this in this order already, I think they're geniuses. And this is what they recommend. So CE is clinical examination, ABI is obvious, and DUS is duplex ultrasound. And these are the recommendations from the Society of Vascular Surgery that came out this year. So everybody believes in an evaluation at baseline. You will notice that duplex ultrasound gets a plus minus in the vast majority of categories. Why? Because if the clinical examination is normal and the ankle brachial index is normal, or what it was the last time, you do not need to do another ultrasound. You will notice that infrainguinal vein grafts are the only ones that have a mandated measurement at 3 months because they are most likely, A, to have a problem, and B, to be fixable if you find the problem early. Everybody else and all the other measurements, and by the way, I want to make this clear, this is for open, 6 months, 12 months, and then annually. Okay, so again, the duplex ultrasound comes into play for most of them, aortobifemoral, iliofemoral, femfem, and axfem. If there's an ABI problem, infrainguinal vein grafts, they should get an ultrasound every time. For endovascular, for which there's a bit less evidence, so I think some of this is expert opinion, although I think it's quite reasonable. Again, you can see here that post-procedure at 1 month, everybody gets an exam, an ABI, and duplex ultrasound. At 3 months, when you're below the aortoiliac segments, you get the same kind of examination. For the aortoiliac segment at 6, 12, and annually, it's a duplex ultrasound only if the ABI is abnormal. And then what you can see here is that below that, it's duplex ultrasound at about the same rates as the open revascularization procedures. I think this slide and the one before it is the surveillance schedule that I would recommend, and I think is recommended now by a large stakeholder in the community. So in summary, the need for secondary interventions is high. About 1 in 5 revascularizations need a secondary procedure. Unfortunately, revascularization failure is associated with poor outcomes, so we'd like to avoid total failure of the revascularization. Current surveillance programs lack consistency across different programs in the United States, and I think standardization of screening should prevent the worst outcomes by preventing full revascularization failure. Thanks for your attention. I look forward to the question and answer period.